apologize.
All right, and we have a new thing where we have to, Zoom tells us that recording is in progress, and I have to click. Okay, yes. All right. So, welcome to today's webinar. This webinar today is part of the Upper Midwest Telehealth Resource Center webinar series, and also this topic is brought to us today by the Ohio Department of Health. We are recording today's session and will be made available later on our YouTube page and the Ohio Department of Health State Office of Rural Health. So we are very pleased to have Cameron Hilt with us today to talk about remote patient monitoring and chronic care management. Cameron?
Thanks, Becky. So as Becky said, my name is Cameron, and I work with the Indiana Rural Health Association in a couple roles, but one is I serve as the program director for the Crossroads Partnership for Telehealth. I also work as a data and evaluation coordinator with the Upper Midwest Telehealth Resource Center. So really what I want to do today is break down and do a more in-depth presentation on remote patient monitoring and chronic care management, and ultimately treating patients in their homes. So I really have 5 primary objectives for this presentation today. The first being, what is remote patient monitoring? What is chronic care management? How are they different and how are they similar? So I really, a lot of times you'll hear maybe these things utilized together, or you'll hear either of these things separately. So I kind of just want to dive into and talk about where is some of that overlap. Next, I want to go through outcomes. So for individuals that have started utilizing these services, what are some of the outcomes they expect? And what were some of the outcomes that they really saw? And so when we get to the outcome section, I really want that to really help get the gears turning for you of, if I were to implement this solution, these are maybe some of the areas that I could focus on and some of the potential outcomes I could see. Next, I want to talk about technology and capabilities. Regardless of where you are as an organization, some may be working with some outside vendors. So I want to give a very high level overview of what some of those vendors can do. Next, I want to talk about how do you get paid? So Medicare and Medicaid reimbursement, as well as what does commercial insurance as far as regulations look like for remote patient monitoring. And then lastly, best practices. What are some of the things that you want to consider when you're implementing these types of services at your organization? So let me start with identifying what are some of the differences between the two services. So remote patient monitoring ultimately has the purpose of, and can be used more broadly than chronic care management. So remote patient monitoring does include monitoring chronic disease, but it also can be used for acute care and neonatal care. And it can be used for a much broader number of reasons. Chronic care management is very focused. So it has one purpose, and ultimately that's to manage the care of patients who have 2 or more chronic conditions as designated by CMS. And I'll explain what some of that designation looks like later in this presentation. The next is the complexity. Since RPM really, it can include that acute care. It doesn't have to be for more high complex cases. For chronic care management, it's very important when you bill of how complex that patient is. So if it's a non-complex case, you're going to bill differently. And if it's a complex case, you're going to bill differently for chronic care management. The expectations for 24/7 access to care is different between the two services. That is only required with chronic care management. How you bill is a little bit different for both as well. So RPM is typically billed in increments of 20. Chronic care management is in increments of 20, but if you have a more complex patient, or if you need to bill for over 60 minutes of care per month, then you need to bill with a separate set of complex care codes for that. And the last difference is the care activities. So RPM is ultimately using a device in order to collect different biometric data that's related to that patient. And so it's interpreting that received data that then will inform a patient or a treatment plan. Chronic care management is a whole slew of other things. So it will include the coordinating care for that patient, helping with their medication compliance, the reconciliation, and overseeing self-management of their meds. When it comes to similarities, I will note that some of these similarities are temporarily not similarities, but the initiation of both services before the institution of the public health emergency, or the PHE, was that if a patient had not been seen within 1 year prior to the commencement of either service, that there would be a required face-to-face visit with the billing practitioner. So this typically was during a wellness visit, preventative exam, etc. However, during the course of the public health emergency, that particular regulation has been waived for remote patient monitoring services only. It's still too early to tell if that ultimately is going to be something that stays after the public health emergency, but for the time being, that is ultimately the regulation with that. Staff involved between both are typically physicians, qualified health professionals, and clinical staff. Both are billed on a monthly basis, and they do both require patient consent. And I'm sure it doesn't shock you as you are listening to something related to telehealth that the location is anywhere outside of the hospital. So it does not have to be at the originating site. And then lastly, for chronic care management, there was a 20% patient copayment if there was no supplemental insurance. So if engaged in CCM services and they didn't have any additional insurance to cover the service, then there would be a 20% patient copayment. That used to be the same for remote patient monitoring. However, that is also currently waived during the public health emergency. And so ultimately, looking at some of those similarities and differences, why are these two services utilized together? And really, it gives you a more proactive approach to provide care for your patients. So if you can utilize data that you're receiving on a daily basis through a peripheral device, through remote patient monitoring, those care plans that you're making with patients when you're engaging them in CCM services can come with a lot more backing and a lot more understanding of what ultimately is going on with that patient. So it gives you an opportunity to be less reactive based off of certain things that are happening with that patient, and be more proactive to ensure that they're ultimately getting the best care plan for them. Another thing is that both can be billed in the same month. So especially if you're looking to improve, offer new service lines that can improve your reimbursement opportunities, offering these two services together, since they're deemed complementary services with CMS, can be a really good approach to that. It's not going to be a get rich quick type scheme. However, it can be a way to bring in additional reimbursement for your organization and improve the health outcomes of your patients. And then lastly, it'll give you more objective insight into day-to-day management of a patient's condition. I'm sure any of you, if you're seeing patients, or maybe you're a leader, and so any of the physicians that you work with, it can be really hard to get patients to recall everything they may have done since that last appointment, or to notice differences in their A1C or their blood pressure. So really, this gives you a very objective data set to look at that isn't really subject to a lot of that recall bias that a patient may have. But it also can really help improve that patient satisfaction. So you can be more proactive. You can kind of have some of these conversations that maybe wouldn't be happening otherwise, making that patient feel like they're receiving even better care from you as well. So moving on to outcomes. So as I said again, I picked a variety of different conditions, and I picked a variety of different case studies. This is by no means exhaustive. There's a lot of different research and case studies that you can look at. But as I said, we're going along here, think of certain things that may be important for your patient population or your organization to address, and how these two services could ultimately fit for you. So I do have to do one disclosure. In order to really understand what is some of the capabilities and technology that's currently on the market, we did engage with several different vendors. The ones that are listed on this slide are just a few that we engaged with. We, as the UMTRC, we are vendor agnostic, so we do not openly endorse any of these vendors, nor are these all the vendors that are on the market. So these were only used for demonstration purposes. So when we look at our first case study here, looking at an RPM program that was implemented at the UMMC's Mississippi Diabetes Telehealth Network. Just a few of the things that they found for the diabetics that were ultimately engaged in the program is that those diabetics had 0 hospitalizations or ER visits, as well as they saw an average A1C reduction of 1.7%. And they saw a total annual cost savings of $339,184. So not only did they see some of those positive clinical outcomes that we're always looking to improve within our patient populations, but they also saw its significant cost savings. So especially if cost is a barrier, really looking at what are some potential cost savings you could have as an organization can be a really good metric to look at to determine your feasibility. Looking at another case study, so there was a solution that was implemented at the Children's Hospital of Virginia at VCU Health. And so some of the things they saw is they saw an improvement in early discharge from the inpatient setting of up to 12 to 24 hours. There was 0 unplanned returns to the hospital. There was a 92% patient acceptance rate of telehealth visits. They produced savings in patient travel. Some were having to travel as far as 5 hours away. And it improved clinic efficiency and reduced the number of no-shows. So there's a variety of different things talked here. I know with RPM specifically, looking to see what your patient, how receptive your patients are to the service is a really important first step in identifying if this is a good solution for you. But in this case study specifically, the patients were very receptive. And especially if you live in an area where health access is an issue, really seeing some of that distance saved is something that can be really impactful in showing the potential benefit of utilizing an RPM service. The next case study is focused on congestive heart failure, CHF patients at the University of Pittsburgh Medical Center. And so they saw for those members that are 65 and older, so it's looking at that Medicare population, they were 74% less likely to be readmitted to the hospital within 90 days of discharge. With any congestive heart failure patient, that is usually a huge focus. So it kind of helps illustrate some of the fit that an RPM service may have to that particular patient population. Those Medicare patients that were enrolled were much less likely to be readmitted in general. So even past that 90 days of discharge. And then over 92% of patients were compliant with the program. Now, looking at a circumstance where they utilize both RPM and CCM together, we have an example from the Patient Provider Telehealth Network in North Carolina. And so really, they saw some of these general outcomes, such as increased access to information for providers and improve their decision-making. It helped facilitate the patient engagement, access to care, as well as that patient's management of their chronic disease. And then they saw significant improvements in health outcomes and reduction in hospital-related costs. But a couple of things to note that I think was interesting from this particular group that utilized RPM and CCM together is some of these quotes that they pulled from both patients and providers at their site. And so I'm not going to read this verbatim, but essentially this first quote is talking about how really having the data from an RPM program that was sending all of their data to a care manager really helped them to understand how a donut or a hamburger ultimately impacted their health. And so it helped create an additional layer of accountability, as well as also improving that patient's education of their condition and how their decisions ultimately impacted their health. And so it really can have some positive behavior change that can come from utilizing those two services together. Another patient commented that it really changed their relationship with their doctor. It didn't really feel like they had to start from ground zero. Ultimately, if they had readings that were outliers, the provider already knew about it and they could address it with them. And then lastly, from a provider standpoint, they're kind of just reiterating that it really helped improve the behavior of patients, because they could really see the impact that their lifestyle or their decisions could really have on their chronic conditions. Now, looking at chronic care management on its own, Medicare actually conducted their own study on CCM's effectiveness. And this was done through a retrospective analysis in 2017, which utilized 2 years worth of claims data for patients that were in CCM programs. And so they really saw a lot of positives when it came to cost savings, especially on a per patient per month basis. And so at 12 months, they saw they were saving over $11 per patient per month. But they saw as those patients stayed enrolled in those CCM programs that savings more than doubled for those patients. And so it increased to $30 per patient per month when they were engaged for more than 12 months. As well as it helped reduce their hospitalizations by 4.7% and their ED visits by 2.3%. So I know that's a lot of numbers and data, but really this, like I said, if this kind of helps you connect how these two services can ultimately be used to address real problems in your organization, your patient population that you're really hoping to address. I meant to say this earlier, but the way that I built this presentation is for it to essentially be a toolkit. So I have lots of hyperlinks that will take you directly to the things that I'm referencing. So if you're interested in that, ultimately those slides are available, but you can go and follow those links yourself if you're wanting to do additional research yourself. Now moving on to technology and capabilities. So before I really dive into some of the technology that can be utilized, I have to make one distinction with RPM specifically. So if you are looking to bill for RPM services to Medicare, it's very important that it meets the FDA's definition of a medical device. And so if you need more description of what that looks like, it's ultimately in that 201H of the Federal Food, Drug, and Cosmetic Act. But the most important thing is that device has to automatically upload patient data. It cannot be a manual entry from the patient. So that's just a stipulation that Medicare has when it comes to the device itself. Now, when it comes to the delivery of RPM services, it can really be done in a variety of different ways, and it depends on what patient population you're treating, as well as the delivery model that makes the most sense for you. So the first is a personalized home kit or a health kit. Essentially, that is just a kit that gets sent home with a patient that comes with a tablet, as well as some of those peripheral devices that I have listed below, which would be a weight scale, blood pressure cuff, pulse oximeter, etc. And those are catered towards the specific program that patient is enrolled in. So let's say you want to work with a diabetic population, you may send them home with a weight scale and a glucometer. And so it's catered towards the patient and specifically what biometric values you want to collect and analyze. But they're all sent in a kit that ultimately will go home with the patient. They can also be delivered through a mobile application, which is called a bring your own device model. That's essentially anything that comes from the peripheral device, instead of going to a tablet, would go to a patient's app on their phone. That app would still be linked the same that tablet would. It's just the delivery of it is slightly different. The pros and cons, so the pro of the personal home kit is that especially if you have patients where technology literacy is a significant barrier for utilizing RPM services, those home kits can be a really good way to ensure that those patients have a much easier way that they can be compliant with the program that they're enrolled in. Some vendors will actually offer where they will go into the home for that patient and they will help set up the tablet and the peripheral devices so they don't have to do that on their own. But having that specialized tablet that can only be utilized for that particular purpose can help address some of those barriers. Now, those home kits tend to be more expensive, which can be a barrier within its own right, but that's just something that you weigh out for certain patients. The mobile application is cheaper. However, it is reliant on having a smartphone and also knowing how to utilize the smartphone in order to sync with those peripheral devices. So it can be a good option for some patient populations and maybe not for others. And then the last mode of delivery is that it can actually be delivered through interactive voice response. So that's where you would actually speak in the biometric values and it would be recorded that way. Here's just a few examples of what some of those home kits will look like. As I said, these are just used for demonstration purposes. We're not openly endorsing any of these vendors. But as you can see, it typically comes with a tablet, as well as some of those peripheral devices. So when some of you, when you are looking to implement these services, perhaps you don't really have the capability to take all of these things on internally. And so you may be looking for a vendor that can ultimately help you to deliver these services. So when you look at a typical RPM vendor, these are some of the main support that they will be able to offer you. So the first one being clinical alerts. Essentially how this works is those peripheral devices will feed data into a database that can be pulled from the provider standpoint or whoever's looking at that data. And what it will do is it will help sort patients based off of their condition into certain categories, as well as, let's say you're looking at a diabetic population. If you want to be alerted when a patient has a A1C above 8.0, you can set that alert so that that patient, anytime there's an alert, they would come to the top of your list. So you can ensure that you're connecting with patients based off of the priority level of their condition. So if they're getting those higher biometric values, then you will get alerted and they will be basically pulled as a priority when you're looking at the data in that vendor's database. The second is reporting. So you'll get some additional data capabilities in order to report out on those patients and being able to track their biometrics. The other option they can offer is logistics support as well as in-home kit delivery and installation. So that can be huge if you're really not wanting to have to be the person that has to deal with sending home kits home with people, figuring out how to install it. So they can offer a lot of that support, which can be really helpful. And then the two others, one is time tracking. The time tracking specifically is helpful when it comes to billing. So if you don't have some sort of system in place outside of a vendor helping you, you may have to be tracking that time manually, which can be really burdensome whenever you're trying to bill, since you have to bill in those 20-minute increments. So some vendors will have it to where it automatically tracks all that time that is being spent with a patient. So it will make billing for that patient much easier. And then lastly, some vendors, and I will note that not all vendors have the billing support. There are some select few that do have that billing support that can help provide some guidance on how do you maximize reimbursement for these services. So if an RPM service is new to you and that support is really important, you may want to make sure that your vendor ultimately has the capability to help to some capacity in that area. Now, when you look at CCM vendors, there's a lot of overlap. So you'll see clinical alerts that will be similar. Some will also have RPM capabilities with the CCM as well. And you'll have some billing support and time tracking. The two distinctions that a CCM vendor can offer, some can actually help with risk stratification for your patients. So eligibility for CCM services can be one of the more difficult parts of ultimately receiving reimbursement for those services, since it has to be 2 or more chronic conditions, and those conditions have to be, they have to last for at least 12 months or more. So basically what this will do is it will automatically help identify those patients that are eligible, so that you don't have to do a lot of that work on your own. And then lastly, nursing support. So perhaps you don't have the staffing available to can ultimately do the CCM services, come up with the care plans, follow up with patients. Some will actually have some of that nursing support as well. Okay, now moving into reimbursement. So I'm going to give a very high level overview of reimbursement. I will direct you to a lot of resources that will talk about more specifically some of the ways that you can make sure that you're on top of everything and really understand the trends in reimbursement for it. But I want to note that especially for these two services and RPM services in particular, as we've seen a lot of the telehealth restrictions be loosened during the course of the COVID-19 pandemic, we as the UMTRC feel very confident that especially RPM services will get more and more traction and will be easier and easier to reimburse and to provide. And so when we're looking at RPM services specifically, these are the 5 primary codes that are billed in order to receive reimbursement for the services. And so you'll notice that some of these are some initial setup or the actual collection of data, whereas some are going to be focused on those particular time increments. So the 99457 and the 99458. Which are billed in those 20-minute increments through the RPM service. So a couple things to note from those codes is, again, this is open to anyone with acute conditions as well as chronic conditions. Medicare has some additional guidance of what that looks like, and in the 2021 proposed physician fee schedule, it used to be limited to established patients, which is currently waived during the COVID-19 public health emergency. It's important for RPM that you have to collect at least 16 days of data during a 30-day period in order to bill for those services. And certain codes, such as the 99453, can only be billed once per episode of care. And so that code is about the initial setup. So that's kind of broad overview of the typical codes that you would bill for RPM, as well as some of the stipulations that are attached to it. When you look into Medicaid, it gets a lot more complex. So for Indiana, I won't go into huge depth here. So some of you here may be from Indiana. But really the main thing is that you have to be a licensed home health agency. So if that applies to you, I do have a link that will take you directly to the requirement that Medicaid has in order to get more information as far as what eligibility looks like in your state. For Illinois, completely different than Indiana, and it's limited to home uterine and pregnancy-induced hypertension monitoring with prior approval. Now, there's a lot more detail that goes into eligibility for Illinois. So again, if you're in Illinois and you're looking to bill for Medicaid specifically, I also have the hyperlink included here that you can follow in order to get more information on that. But for those of you who are located in Ohio or Michigan, currently, there's no particular requirements surrounding RPM services in your state. Now, I want to clarify that doesn't mean you can't bill Medicaid for those requirements. However, you want to consult a billing professional in your state to ensure if you're going to bill for those services, that ultimately you're going to be able to get the reimbursement that you would need. So again, this is the reference for any of you located in Indiana. This is the provider reference module that will talk about more of those requirements for remote patient monitoring. And for Illinois, that guidance for remote patient monitoring is located in the handbook for providers of medical equipment and supplies. So both of those things are provided as well. When you look at commercial coverage for remote patient monitoring, Foley and Lardner is a law firm that focuses specifically on, they have a lot of focus on telehealth, remote patient monitoring services. And so in the report that they released in February of 2021 this year, they found that there was no particular statute that required commercial insurers to cover RPM services. And that is true across the board of Indiana, Ohio, Michigan, and Illinois. Now, we as the Upper Midwest Telehealth Resource Center will continue to monitor that to see if that changes over time. However, if you have patients that are on commercial coverage, it'll just be important for you to ultimately double check their eligibility requirements to ensure that you are going to be reimbursed for those services if you're providing them. If you're looking for RPM resources in general with billing or implementing the program, a few resources that you can refer to is first the Center for Connected Health Policy. So they have an interactive map, and remote patient monitoring is ultimately included on that app. So you can get policy updates, and it will also help give guidance on Medicaid requirements for your state. And then Foley and Lardner, LLP, who I just mentioned, they do have those policy updates, but they also have FAQs and billing. So if you want to get more information on billing or have certain questions when it comes to billing for RPM services, they do have a lot of those resources on their website. And then lastly, I want to put in a plug for our sister TRC in the Mid-Atlantic, who developed an RPM toolkit that really takes you from A to Z. So looking at vendors, what staff do I need? How do I actually implement an RPM program? How do I evaluate it? They really kind of have an exhaustive toolkit that will really help you get started and help you as you begin to implement these services if you go that direction. Now moving on to CCM services. So as I stated before, CCM services predominantly fall in these two buckets. So there's the non-complex codes, which you'll see are billed in an increment of 20 minutes or at least 30 minutes. And then there's the complex codes, which are billed in the increments of 60 minutes or an additional 30 minutes on top of those 60 minutes. So part of the difference between the two codes is going to be the amount of time spent with each patient. However, each set of codes has its own eligibility requirements in order to utilize the service. So when you look at the non-complex codes, really the 3 points that is required for that patient to be eligible is they had to have those 2 chronic conditions. They have to be expected to last at least 12 months. So it doesn't mean they've had to have them for 12 months. It just has to be expected to last at least 12 months. So that rules out any acute conditions that would last less than those 12 months. The chronic condition must place the patient at significant risk of death, acute exacerbation, or functional decline. And a comprehensive care plan must be established, implemented, revised, monitored. When you look at the complex codes, so it requires all of the eligibility of a non-complex code, plus the additional 3 requirements. And that is, you need to either have a substantial or an establishment of a comprehensive care plan. The patient must require a moderate or high complexity for medical decision-making, just meaning that there is much more time involved in order to coordinate and work with that patient. And then it has to be at least 60 minutes of clinical staff time that's directed by a physician or other qualified healthcare professional per calendar month for that patient. So that's some general guidelines when it comes to chronic care management. Now, CCM has a lot of resources that you can go if you're interested in learning how to implement or to bill for the service. And so some are the same. So Foley and Lardner, they also have CCM guidance, but CMS has a lot of resources. So they have a professional toolkit, which will explain why and how you use the service. They'll have a partner toolkit that comes with activities to get started, as well as posters and postcards. But also they have a very in-depth CCM Services fact sheet. So if you want to see more detail of some of the eligibility and requirements, I gave you the big things. That would be a good place to reference, as well as they have a lot of FAQs about billing for the services as well. So CCM has a lot of that guidance that's coming directly from CMS in order to get people started and reimbursed for the services they're providing. So now that we've talked about how do you get paid for the service, the last thing to really talk about is determining if these services are a good fit for you and some best practices if you're looking to implement either one of these services in the future. So first, you really need to evaluate if these will fit within your organization. And really the first step to that, as I was saying, when we were looking at outcomes, trying to think of what is a focus area that I could use CCM or RPM services to address. And even if you're looking at those outcomes, still drawing upon a blank, really there's a couple areas you can go to in order to help you identify that focus area for either of these services. The first is utilizing the data that you ultimately have through your EMR system, seeing if there's any trends when it comes to either certain chronic conditions or acute conditions that would be a good fit for either one of these services in order to either reduce cost, reduce wait times, reduce no-show rates, to improve biometric values, really looking at your data to have a compelling business case of why it would make sense to provide these services for that particular patient population. The next two is whether you're someone who's directly providing patient care or you're overseeing people that are doing the care. Collecting feedback is a huge piece of this too. What are some of the gaps in care that some of the clinical staff is really seeing that could be addressed by either one of these services? So getting that, following the data and collecting the feedback will really help inform a lot of that focus area and the fit that either of these services you would have for your organization. The next is then to prioritize those problems, because you might have just found a whole lot of things through the data that you looked at and the feedback you collected. So really prioritizing those problems based off of what you feel like will have the most impact for your organization and for patients, and really envisioning what are some of those expected outcomes. So what has research ultimately said that these services can provide in this particular focus area, or what is some case studies from other people that are similar to me of what they saw whenever they implemented either one of these services. And then the last piece will ultimately be evaluating. So the first step of that is if you're needing to outsource to a vendor, so evaluating that vendor based off of your problems identified, but then ultimately evaluating the program as you implement it to ensure that it's ultimately bringing those expected outcomes to the priority problems that you identified. So a couple of questions, especially if you're looking to work with a vendor, a couple of questions I would encourage you to address with them whenever you're looking are really these four options here. And so one is how long has the vendor been providing services? So this may be more important for some than others, but especially in the technology space and the amount of vendors that are available. There are a lot of new innovative companies that are doing brand new type of work, but maybe don't have some of the track record of how their services have been implemented in the past or have met certain needs. So as an organization, you need to kind of feel out what is your comfortability with some financial risk, depending on if you want to work with a company that has a long tenure with ultimately providing the service, or if you're looking for something that's a little bit more innovative and can help meet a need, but maybe hasn't been utilized a lot in the past. So that's an important question for yourself, but also for the vendor as well, to figure out if they're a good fit for you. The second is, does the solution cater to your priority problems you want to address? If you want to have a RPM or a CCM program that is focused on congestive heart failure, you need to make sure that vendor ultimately has a very good understanding or experience in implementing that type of solution for you. And so even there's been some movement when it comes to utilizing RPM services in behavioral health that's very, very new, but maybe not all vendors offer that. So if you're looking for that type of support or that type of program, you need to make sure your vendor ultimately can offer that to you. The next is, do they have any notable case studies or have they worked with clients in your area? This just helps you have more confidence that ultimately they can deliver on what they're promising. And especially, I know that every single hospital and organization, their patients are completely different, but being able to understand, do they have some experience? If you're a rural hospital, do they have some experience working with rural clients? Do they have some experience with working with some of the particular patient populations that I'm wanting to target with these programs to ensure that ultimately it will be successful within that particular population as well? So that can be a good thing to evaluate as well when you're looking at different vendors. And then lastly, what is the type of support you need? So for example, like I said, with the billing support, if these services are new for you and maybe you don't have a whole lot of support when it comes to billing for these two services, looking for vendors that can offer that billing support may be more important to you than maybe someone who has some more of those resources or a billing department that can really take care of all of those needs. So that's something a question to ask yourself, but also to ask that vendor as well. And then lastly, you want to know that it's going to fit into your culture. So really, when you are first assessing the service needs and defining the environment, which is really where you're starting to identify that those problems that could be addressed by this, you need to have someone in your organization who's essentially your remote patient monitoring, chronic care management champion. So a person that is passionate, driving these things forward, ensuring that ultimately it doesn't get lost in the shuffle, but ultimately that it's being moved forward. And also defining how willing is your organization to offering these two services. So does it fit well with some of the priority problems that you've identified? Next, you want to develop a plan. So do you have an organizational model or legal or regulatory constraints that would make implementing either of these services difficult? So those are two important questions just to think through before implementing. And you also may consider creating a work plan or a workflow, identifying if there's any existing procedures that would need to be modified in order to provide the services. This will save you a lot of heartache on the back end if once you've implemented things, you didn't have a clear work plan or workflow and procedures currently weren't built to work with these types of services. So building that plan will make it a lot easier so that when you do start to implement and maybe start doing it in a phased approach, you can really test out to see if what you created ultimately works best for your organization. And then lastly, as you begin that phase implementation, begin to monitor what's going on with that. So testing the platform with patients, so ensuring that you're getting positive feedback from your patients and their willingness to be a part of either service is important, because that will go hand in hand with some patient volumes and utilization. But also another important piece is as you're looking to identify your priority problem, one important thing would be to make sure you capture some baseline data. So when you're implementing these programs, you want to be able to tell in 2, 3, 4 years after you implemented it of this is what our patient population looked like before, and this is ultimately what it looks like now. So these were our projected outcomes, but ultimately now, after X period of time, we've seen improvement in our baseline measures. And if you haven't seen improvement, ultimately figuring out what the cause of that is, so that you can then improve upon the service line to best meet the need for your organization and your patients. So those are just a few things to consider when it comes to culture and as far as actually implementing the service in your organization. And so really that wraps up my time today. I really appreciate all of you that have joined today, and I did include my contact information. Please feel free to reach out to me if you have any additional questions outside of this presentation today. But I'll go ahead and pause here and pause for if anyone has any questions moving forward.
Absolutely. Thank you so much, Cam. We did have a couple of questions come through. The first one, let's do this one first. Have you seen a return on an investment analysis for RPM?
I guess, and I don't know if this person wants to put it in the chat, but I guess what particular return on investment are you thinking? So there's definitely, so with one of the examples that I went through, and I don't believe I put this in here, but it's in the document itself. The cost savings that they had in year one was enough to recoup all that they put into implementation. So they put in the money for implementing the service, and this was focused on a diabetic population. They put in the money to ultimately implement those programs, but through just the cost savings, so not even the billing, not even billing for those patients, just the cost savings they ultimately had an immediate return on investment for that. So that's coming from more of a cost perspective, but from a clinical perspective, some of those I haven't seen exact dollar amounts necessarily tied to if you can reduce a A1C by 1.7%, how much does that equate to $1? However, at least the general clinical outcomes they have, but at least in that example, when they were working with predominantly a Medicare population, those cost savings already produced a significant return on investment.
Okay, thank you. And then this one, I'm not quite sure I answered it, so I want you and I to talk about it a little bit. For patients with diabetes, does this include continuous glucose meter or glucose monitor in addition to glucometers? And I wasn't sure what the question was, if they're saying does the RPM program, and I'm not sure if they were talking RPM or CCM, I think RPM. I think the question is, does the RPM program cover the cost of the constant glucose monitor? And my understanding is no.
Oh, I see. No, I wouldn't think so. Can you read the question for me one more time? Sorry, Becky.
For patients with diabetes, does this include continuous glucose meter, CGM, in addition to glucometers?
Yeah, I may have to look into that one. I'm not sure off the top of my head, but I'd be happy to look into that and see if I can get some more information.
All right. So if that person wants to follow up with me or with Cam via email, please do so. My understanding is that the reimbursement for either CCM or RPM is based on the time, the 20 minutes or the 60 minutes or the 90 minutes that is spent with the patient, but that whatever normal billing for an endocrinologist or what do you call it, the DME, durable medical equipment. So that would be like the glucometer to test the blood sugar, any insulin pump, any constant glucose monitor would be billed as DME, which is totally outside of these two programs we're discussing today.
Right. Because most of this is going to be focused on all the billing codes are focused on the transmission of data itself and not necessarily the equipment that was used. So the equipment, just as you said, would probably come more through DME versus the RPM codes itself.
Right. Somebody else said there are different CGM codes. I don't think you can bill RPM codes for a CGM data capture. Maybe that's what she was talking about, was the data capture of the CGM. Okay. Can you comment on any research that RPM adds strain to nurses' workloads?
Yeah, I don't know if I've read anything specific about it. I would be curious as well, and I mean, I think it's a legitimate issue because I mean that's also why some of these programs ultimately offer the nursing support because it can be an additional service on top of those, and if the nurses are already having a lot that they're having to work with, it can create an additional workload for that. So I know absolutely that is a concern. I would be curious myself and would be happy to look into that a little bit further to see if there's any specific research that points to the workload that may bring upon the professionals that are ultimately providing the service.
Mm-hmm. Yeah, absolutely. I know a grant-based program that we had several years ago around CCM here at IRHA included the service, it's not appropriate to say because we're on a UMTRC federally funded call, so we're not going to play vendor favorites, but that vendor did offer that nurse support on top of their services, of course, for an additional fee. But I also think that in certain situations, especially if, say, that the hospital organization is part of an accountable care organization, they might either hire new staff or take an existing nurse, give them care coordination training or case manager training with behavioral interviewing, motivational interviewing, behavioral interviewing, and have them just do that job. I think that's when CMS released these codes and introduced these programs. I think that was what they thought would happen. Now, the reality probably is a lot of nurses that got told, hey, in addition to everything else you're doing here, do this. But I don't think that's the optimal situation.
Right. And I think there's still a lot of support, especially if you can find the right fit for your organization and like the condition that would. So that's kind of where prioritizing your problem area is really important. Of if cost is an issue, looking at some of the areas that would have the most immediate return on investment, and really seeing. So even if you have to pay for additional nursing support, it's not, you're not in the red when you're implementing the service. And you're also improving the care directly for those patients because they're better connected to care than maybe they would have been outside of that. But yeah, that's where connecting it to the right problem area so that if your nurses are already way over capacity, then you want to be able to afford that nursing support to ensure that the services are delivered well and not at the expense of your staff.
Right. Well, and something that I remember from the CMS literature on CCM, not necessarily on RPM, but that it doesn't have to be a nurse. It could be a clinical nurse CNA, whatever, clinical nurse assistant, or an LPN, or anyone else that has the appropriate training. So that might be something to look at, is, that person in that role might be someone who makes less than an RN per hour to make it cost effective.
Mm-hmm. Yeah, and Medicare on their, so actually the CCM resource that I have, give me 1 second. Yeah, I believe it might be the services fact sheet.
Mm-hmm.
It will actually say what, because it always is very broad. So it's qualified clinical professional, which that leaves a lot of room for interpretation. So I think that's the CMS CCM service fact sheet will actually break that down to what professionals are eligible.
Mm-hmm.
So especially if you're not wanting to push it onto your nursing staff, you might have some additional professionals that could ultimately help take the workload off of them.
Right. Absolutely. All right. Well, we are almost at the end of our time. I do want to be respectful of everyone's time, so I'm going to go ahead and ask Carolyn to put the survey link into the chat, and also give a last call for any questions or comments before we end the session for today. And again, because we are federally funded, the information from the surveys is very useful to us as we look at future programs, future topics, and also taking feedback from our different training sessions to our funders at the Ohio Department of Health, or I'm sorry, the Ohio Department of Health and the State Office of Rural Health, as well as HRSA. So please take a minute or two to fill out that survey. All right. Well, we appreciate your time today and hope that this was informative and useful for you. And Cam, thank you again so much. You're a wealth of knowledge.
Thank you, Becky. Appreciate the opportunity to speak.
All right. Take care, everyone.